So welcome everyone. So my name is Matt Cicchini, and I'm here with Sanjay Mukhopadhyay, and we're going to be talking today about the histology and pathology of the mediastinum to kind of give you a basic intro of some of the normal of what's going on. And so we first wanted to start with this kind of a very busy table and this diagram, but I think it's got a lot of great information here that we can really start to break up and build this differential of mediastinal lesions. And I think this is something that is really important and kind of comes up in multiple formats, either on board exams or in working up differentials or in clinical cases. Um, so Sandra, did you want to start talking about some of the maybe kind of how we break up these different components of the
Yeah, I like
mediastinum?
the, okay, let me take the anatomy part and you can take
Sure,
the tumor part. How's that?
sounds
I
great.
love the anatomy part. So if you can just point at stuff as I talk about it,
So
Matt.
I got my pointer all ready to go.
Yeah. So I mean, I learned a lot while reading about this, like a lot of really interesting anatomic stuff. So let's start with the junction of the sternal head with the body, that junction. Yeah. So that junction where the sternum, the head of the sternum meets the body is the manubrious sternal uh, uh, joint, and at that joint there is a plane, and that plane is that black line that goes all the way back to the spine, and that plane is called the plane of Ludwig, which we mentioned also in the table. That plane of Ludwig actually separates the superior mediastinum, which is the orange cone or triangle or whatever, from the inferior mediastinum. And the inferior mediastinum is what we typically divide into anterior, middle, and posterior. So I didn't know that before. I'm so embarrassed to admit, but it's not the mediastinum that's divided into anterior, middle, and posterior, but the inferior mediastinum.
Yeah.
So in the inferior mediastinum, it's pretty easy if you keep the heart as a reference. Anything ahead of the heart is the anterior mediastinum, which is the blue. The heart and anything inside the pericardial sac and that middle region is the middle mediastinum. And then anything behind that is the posterior mediastinum. And nowadays, it's fashionable to call this, um, I think, prevascular. Is it prevascular, Matt? The first one?
I think so.
Prevascular, vascular, and postvascular, something along those lines.
Yeah, I don't know. I still think in anterior, middle, and
Yeah, me
posterior.
too. I'm old fashioned like that. But
Yeah,
people now, use a kind of different terminology, which means essentially
yeah.
the same thing. And remember that the inferior border of all the inferior mediastinum is the diaphragm. So essentially, we're talking of when we talk of mediastinum, we're talking of all the structures that are between the two lungs, and then we're talking of things above and below. And the table, I think, one of the really nice things that we've done in this table is shown both the boundaries and the normal structures that occur in that compartment. So, for example, I won't go through all of this, but for example, if you look at what happens in the anterior mediastinum, it houses and cushions the thymus. So the thymus is partly in the anterior mediastinum and protects the heart. And so that this table gives you a lot of information about just the normal counterparts before going to the tumors that occur there. Over to you, Matt.
Perfect. And so, so I guess we can go through the differential now, I guess, for these different components. And so the anterior mediastinum, which I think is probably the most common place that we'll see lesions or specimens from, or most commonly comes from the differentials. So I was always taught to think of the T's, and so I think that's a nice way of remembering it. So you have your thymoma, you have your thymic cyst. The lymphoma, they kind of get in there by calling it a so-called terrible lymphoma, or I don't know. I think that's a bit of a stretch, but it's a way of, I guess, remembering it. And then you can also have thymic carcinomas. And then germ cell tumors, which can commonly be teratomas to keep with the T mnemonic. And then remember as well that you can also just have thymic hyperplasia, so it doesn't actually have to be a neoplasm. And then thyroid, so you can actually have goiters that can extend all the way down into the mediastinum as well to give you a mediastinal lesion. And then another pseudo T is a parathyroid adenoma. So remember that you can get parathyroid tissue all over the place, including in the mediastinum. So that's also in your differential. So the differentials for the anterior mediastinum are there, and largely in the T's that at least kind of you can push them into a T. The middle mediastinum, which is where we have the heart. This is a smaller differential, and we do have some benign cysts that are often pericardial. You can get metastases in this space. And then remember that you can get all kinds of abnormalities with the vasculature in this space. So you can get aneurysms and dissections, which can present as a middle mediastinal mass. The posterior mediastinum, so this is where we have a lot of our nerve structures. So you can get all these neurogenic tumors, including schwannomas. And as well, the esophagus is actually in this space as well. So remember that you can get esophageal malignancies arising in this space. And then last but not least, the superior mediastinum, which is on top. You can get many of the similar things as the anterior. So you can get thymomas and thymic cysts. You can also get lymphomas in the space, and then often thyroid lesions, right? Because this is the place that would be most commonly to get these mediastinal goiters extending down, and as well as these parathyroid adenomas. Anything else you wanted to add with this,
Yeah,
Sanjay?
this is a great summary, man. I think that superior mediastinum, the way I think of it is like the intermediate zone between the neck and the chest.
Yeah.
So it kind of gets things from both ends, like it gets neck lesions going down, chest lesions going up.
Yeah.
And so thymic lesions can also occur there. The posterior mediastinum, one thing I love to add, there's the Hattori cyst.
Oh, yes, that's a good thing. Do you want to talk a little bit about that, or?
Yeah, the paravertebral Mullerian cyst of Hattori,
Yes.
described by, I think his name was Hideo Hattori in chest in 2005, I think. Just a beautiful Mullerian Paxate positive cysts, benign, beautiful. They always occur in women
Yeah.
next to the vertebral body. It's a beautiful benign diagnosis to make. Paxate is the great stain to do.
That's
Also
great.
stains with ER. And the middle mediastinum, the one thing I would say is a paraganglioma would be
Yes.
the other thing to add
Yes.
to that list. And of course, lymphomas pretty much can occur anywhere,
Anyway, yeah.
but because lymph nodes and everywhere, so lymphomas everywhere. And these cysts turn out to be very common everywhere. One really nice paper I read recently was by Anya Rodin. Did a very nice paper from the ITMIC database where she looked at all the various, how
Yeah.
common are these things in the ITMIC database. So a lot of this data actually comes from that paper, is
Yeah, it
a
was a great
more
paper.
updated version of what we already knew.
Yeah, and I guess another important thing that I've seen is that it would be very uncommon to have a thymic lesion in the posterior mediastinum. Would you agree with that, Sanjay? Or
Very what, Matt? Uncommon?
uncommon to have a thymic lesion, like a thymoma, or they're really largely in the anterior. And I think if
Yes,
if the lesion is clearly in the posterior, it would be uncommon to have
uncommon.
a thymic lesion there.
I really think, like you said, posterior, your first thought should be a neurogenic tumor of some
Yeah,
kind. Schwannoma, ganglioneuroma, malignant peripheral nerve sheath tumor,
yeah.
Tarlov cysts, which are also
Yes,
neural. So those things would be posterior mediastinum. Yeah.
definitely. Okay, so clear that, and then let's move on to the next. And then I thought we talked about this in one of our other videos, but I thought we could talk a little bit more about the normal thymus that you would see.
Yeah.
And
You want to give it a shot, and then I'll add if you.
that sounds great. So I assume this is from a younger individual because the thymus is kind of peaks in size around puberty, which we'll show on the next slide. But here you can see that there's a very substantial amount of tissue that we have here. And I really love this low power shot here, which shows these more blue areas here, and then these kind of lighter pink areas here. So this is the cortex and the medulla here, or medullary areas, if you will, depending on, I think there's still some debate on how we should say that. And then here is kind of a medium power photo, which nicely highlights these more cortical blue areas here, and then these lighter staining medullary areas here. And then I want to bring your attention here to this area here, where you see this really pink area here. And then we look at higher power, we can actually see it's got this bit of this squamous type of differentiation to it. So this is Hassel's corpuscle here, which is a key feature in identifying thymic tissue here. And this is just kind of highlighting more of these medullary areas here as well. So this would be the normal structure that we would see in the thymus that has these nice architecture with the differentiating these cortical and medullary areas. Is there anything you'd like to add to that, Sanjay? Or?
No, that's great, man. I think what I would add to that is in a practice that mostly deals with adult patients like
Yeah,
mine. Like I don't
yeah,
see pediatric anything. I rarely ever see this kind of a beautiful
Yeah.
thymus, beautiful, juicy thymus with all the classic architecture. What most people will see in adults is atrophic thymus, which looks nothing like this.
Yeah.
So this is the ideal, that the childhood thymus, which then gradually involutes and all this
Yeah.
epithelial stuff and lymphoid stuff starts to disappear. And what you're left with is mostly fat.
Which I think is what we have here. So this is actually what you were talking about there, Sanjay, whereas we mostly have fat and some vessels here. And then this is the real remnant of this thymic tissue, which is really quite atrophic. And this is just data showing of thymic weights over time and showing that it does peak around 11 to 16 age group. And that's kind of the time where the thymus peaks in weight and then will decrease in size over that. And so you expect in older individuals that they'll have kind of a smaller thymus. And these tables are basically what's used for making a diagnosis of a thymic hyperplasia, right? And so if you
Yes.
fall beyond standard deviations of these means, then that
Yeah.
will put you into the thymic hyperplasia for
And
age.
can you tell that little story? Because I think that's a very interesting story of how you discovered this. So when we went looking for
Yeah.
the source, what happened? Can you just correct the record here? Because in the previous one we said we used the AFIP mediastinal fascicle for that, and then
Yeah.
we looked at the references and what happened after that.
So we kind of went down a rabbit hole actually. We looked at the FIP, and then they had cited histology for pathologists, right? Is that right, Sanjay? And then we went there, and then they had cited some papers that we had difficulty finding, and then so we actually went back and reviewed all the literature, and it really appears that weighing thymuses was really in vogue around 1920s, 1930s. And so we went back and found and read these really, really old papers. And I think the study we ended up finding was a study that was actually started um, before World War One, and where they were weighing all these thymuses in autopsy series in England. And then the study was put on hold because of the war. And then the lead study author died. And then so they had to and this was all in their introduction of the paper, which was interesting. And you don't really see any more about the history of it. And then someone else took on the study and completed it. And so but they actually weighed hundreds of these thymuses in all these studies, and it actually is the most comprehensive series of thymic weights per age group. And so that's where we got this, and I think it nicely shows conceptually what we know, where we do see this peak here at puberty that then declines over time. And so
So what does the weight become like? So it's about 20 grams or less, right?
yeah,
Uh,
basically, yeah. So here's 20 across, right? And
20
so
grams or less, and then the peak weight is really about 35 grams.
yeah, I believe so. Is
Yeah.
somewhere around there
So at
between
any point, if you have a 50 gram or more thymus, it's abnormal. Correct? It cannot be normal if it's 50 or more. Of course,
basically, yeah.
it's always complicated by the fact that there's fat there, and
Yeah,
you don't know if the fat is part of the thymus or not. But if you take away all that complication, if you just think of I weighed it and it weighs 200 grams, it's got to be abnormal. So it's
exactly.
not in the range of normal thymus anymore
Exactly right.
for any
And
age. Yeah.
yeah, but yeah,
That's
so
a great piece of investigative work.
yeah,
Matt.
yeah,
We have immortalized it. It'll get immortalized on YouTube. Your sleuthing.
yeah. I do enjoy reading those older papers. I think it's, and even just like looking at their graphs and thinking of like how they made those graphs in the 1920s and things, right? Like there's no Excel or computers, and like, making all these lines and plotting everything by hand is something that we don't have to think about anymore, right? But
Yeah. Yeah.
it's interesting. So yeah, so I think that's what we have here for the normal kind of thymus and kind of approach that. And I think this pairs nicely with some of our other videos on the topic.
Yeah.
And so we encourage people to go watch those videos after.
Great job, man.
Thanks so much.